So this is a slide which has, I'm going to go through, I have a number of slides that look just like this, and I want to go through this step by step. This discusses the mechanisms of malignancy. So here's a cancer cell. Cancer cells secrete their own insulin. They have 6 times more insulin receptors per cell. I'm going to go through all this step by step with scientific documentation, but I just want to give you the overview. They secrete their own insulin. We know that they have a voracious appetite for glucose, so it makes sense that they would do this, and they do. And they have 6 times more insulin receptors per cell than any other tissue in the body. This produces facilitated diffusion of glucose to fuel the cancer cell processes. On the other side, cancer cells also produce their own endogenous IGF, insulin-like growth factor. I don't differentiate between 1 and 2. In the literature, there was all kinds of debate back and forth over the years about whether it's IGF-1 or IGF-2 or IGF-1 or IGF-2 and which receptor and all that sort of thing. So I just simplified it. In the text here, you'll see articles which have IGF-1, but I will always refer to just as IGF because it's easier. So they make their own IGF. They have 10 times more IGF receptors per cell than any other cell in the human body. This produces a metabolic effect of increased S-phase activity, which equals cancer cell growth. So you have autonomous ability to fuel and autonomous stimulus for growth. Sounds like malignancy to me. And this is autonomous autocrine stimulation. An overview of what we do with IPT is a schema of the mechanisms of IPT. Here we use exogenous insulin, which can react both with the insulin and with the IGF receptor, which are very, very much in excess on the cell surface of cancer cells compared to normal cells. It has a lot to do with the differentiation effect that I'm going to mention. It's very important as far as cancer chemotherapy. Cancer chemotherapy, it's a problem because we can't differentiate between cancer and normal cells. Yes, we can. So this produces, in the cancer cell, we get an altered cell membrane permeability, which increases the intracellular dose intensity of low-dose chemotherapy, which is administered concurrently according to a certain time schedule. On this side, we get stimulation of the IGF receptor, which is a metabolic effect of increased S-phase activity, increasing the sensitivity of the cancer cell to the cell cycle phase-specific anti-cancer drugs. So there's a synergy here between increased intracellular dose intensity and increased proportion of cells in S-phase, and kill cancer cells dead quicker and better.